In case with Schur-X-Ray syndrome and the pupil didn't dilate over 5.5 millimeter, I always use iris retractors. And sometimes it is necessary to support the capsular bag with another iris retractors. So I will stain the capsule using some dyes. And also during the phaco emulsification, I reduce the flow rate and the pressure for the safe surgery. So when I make the incision, I make the incision a little bit anteriorly, and I try to make the two-step incision a little bit longer corneal tunnel. For the, I make in the side port incision at 3, 6, 9, and the tubercle position, and use iris retractors to stretch the pupil. And after making a capsulorhexis, if you noticed, when you make a capsulorhexis, if you find a fold in the anterior capsule, it is a sign of the weakened zonule. And in such a case, I'll carefully perform the capsulorhexis, and I'll change the position of the retractors from the iris to the edge of the rhexis. Thus, I can support the lens. But during the procedure, pupil may become smaller. In the case with a soft cataract, we can manage the surgery in this situation. But the lens was so dense and the zonule was so weak, I used another 4 iris retractors to support the capsular bag. This is my preferred iris retractors. With these retractors, I need to insert the retractor horizontally and then rotate and catch the iris edge. But the other retractor is round, and sometimes retractors moves like this. So I designed a new retractors with a double wire. It can be firmly fold with a normal forceps, like this. And also the stress on the iris edge is less than the conventional single wire retractors. So nowadays I use a lot of these twin wire iris retractors. Make a little bit larger side port incision. I usually make a 0.6 side port, but when you use these retractors, please make 1 millimeter side port incision. Just insert. It is not necessary to rotate the retractors. Go and retract. By single action, you can pick up the pupil edge. So I'll show you a case. This is a case with an assured exfoliation. The pupil dilate just 5.5, and the nucleus is a dense nucleus and deep set eye and old patient. So I guess this patient has a risky case. So I made a 2-step incision. The incision pointed a little bit anteriorly, and this incision size was 1.9 because 2 millimeter gauge didn't go in. So after dilating the pupil with the retractors, this is a surgical slit attached to the microscope. We can judge the nuclear density with this device. It is very useful. Unfortunately, in Japan, we don't have blue dye, trypan blue we don't have. Only the dye we can use is in the green dye, in the cyanin green. So I have to use this dye dissolved in the cohesive viscoelastic material. And when you perform the rhexis, and if you find these folds in the anterior capsule, this is a sign of the weakened zonule. Sometimes we need a needle or the diamond blade to puncture the capsule. Usually I use this uterata forceps with a sharp edge to puncture the capsule and carefully make the capsulorhexis along the rhexis marker. Then in this case, the nucleus is so dense, I decided to put another 4 retractors to support at the capsulorhexis edge. So once lens is supported like this way, you can perform the procedure normally after performing the hydrodissection. Please ascertain that the nucleus can rotate freely in the capsular bag and then fill up the chamber with dispersive viscoelastic material. And I always pre-chop the nucleus, supporting the nucleus with the second instrument. This is a nucleus sustainer. There's a microball attached at the tip. So you can support the nucleus at the deep equatorial portion. The tip of the sustainer and tip of the pre-chopper and the central hardest core of the nucleus always should be aligned on the same axis or same line so that you can provide a proper counter force to the pre-choppers. Rotating little by little, I will pre-chop the nucleus into smaller pieces. Usually I pre-chop the nucleus into 4 pieces, but in such complicated cases, I will pre-chop further into 6 or 8 pieces. The phacoemulsification will be performed at a very low pressure, 30 millimeter mercury or 20 millimeter mercury. And also I reduce the flow rate down to 25 or 30 cc per minute. After implanting the capsular tension ring, I will enlarge the incision a little bit because in such a situation, I don't like to perform the counter-traction implantation. And the toric lens can be fixed in a good position. So sometimes we have the case of subluxated intraocular lens in such a case. I may have 5 to 10 cases per year of the subluxated lens. So to prevent such subluxation of the lens, I always implant a capsular tension ring in a risky patient, such as the Schur exfoliation syndrome, or in Japan there are many atopic dermatitis patients or the pollen allergy. Patients love their eyes so much, it may cause a weakened zonule. Or the cases with blunt zonule ocular trauma, post angle closure glaucoma attack, or the retinal surgery such as the buckling, or the cases with the high myop. And also for all my multifocal cases, I implant on the capsular tension ring. There are many benefits with the ring, CTR. This is a case of the trifocal lens implanted 3 years back, trifocal toric lens. The lens is floating in the vitreous. So under the operating table, I couldn't see the lens because the lens is somewhere around here. So this is a toric lens. The lens should be placed on this axis. So what I decided is to suture the lens to the sclera. And also this is a fine vision visual lens, and it is implanted together with a capsular tension ring. So my procedure is like this. After the tenon anesthesia, I'm making 2 paracentesis and using fill up the chamber with Viscoat and using with PC9 or pair pack suture, polypropylene suture. I'll puncture the needle and catch the CTR behind and then catch this needle and take it out to the eye and return again, and this time pass over the CTR, and this way I can catch the lens and repeat the same procedure. So you receive a floating lens. I levitated the lens from the limbus using a nucleus sustainer. And I'll puncture the sclera from outside and catch the CTR behind You see the capsular tension ring here. And the suture goes behind, and then through this corneal side port, this is 27 gauge cannula to catch this needle and take it out. Then return through the same side port and catch this needle, and then this time the needle is over the CTR. So in this way, I could catch the CTR and the lens complex. I'll repeat the same procedure. I'll puncture the capsule CTR behind from under and catch it with 27 gauge cannula. There's a small trick. I'll bend the tip of the needle a little bit so that I can easily catch. And then return through the corneal side port. And this time, the needle is over the CTR. In this way, I can fix the lens. If this is a monofocal lens, there's no issue, I can finish the surgery. But it is a multifocal lens. The lens should be at the center of the pupil. So I need to adjust the position of the lens this way. So I decided to make another control suture to adjust the lens position. In the same procedure, coming from outside, pick up the CTR behind and catch this needle with the 27 gauge. This part of the needle is a little bit bent, so you can safely catch and then return it. We can make the postoperatively 1 week, 3 weeks. The suture is covered by the conjunctiva. In such way, I manage the complicated cases. Thank you very much.
Thank you very much, Professor.